Welcome everyone to today's webinar. I'm Heather Punke, Managing Editor with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We look forward to hearing your questions. Additionally, in about a week following the webinar, we will send you a recording of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our first presenter. Dave Giracco is Medtronic's Vice President of Market Development and will start the presentation today. Dave, I'll turn the floor over to you.
Thank you. As a global leader in medical technology, services, and solutions, Medtronic improves the health and lives of millions of people each year. We believe that our deep clinical, therapeutic, and economic expertise can help address the complex challenges such as rising costs, aging populations, and the burden of chronic disease faced by families and healthcare systems today. But clearly, no one can do it alone. That is why we are committed to partnering in new ways and developing powerful solutions that deliver better patient outcomes. It is my pleasure to introduce my Medtronic colleague, Senior Global Marketing Manager Keith Morrison, who will describe for you our quality improvement program for continuous monitoring. This is just one way that Medtronic is partnering to help demonstrate better patient outcomes. Keith?
Thank you. Yes, next please. Hi, and thank you guys for joining today. As Dave mentioned, I'm going to outline the quality improvement program for respiratory metrics and how it can help assess outcome changes post-continuous monitoring. I'm going to start by talking about how the program itself works, and then we're going to hear from Barton Healthcare on their experiences with this program and the data they've obtained and what it has meant for their facility. So the goal of our program here is to really provide your own data back to assess how your respiratory metrics have changed pre and post continuous monitoring. Our goal is to partner with you with healthcare institutes to take the burden off pulling and obtaining the data and just providing your own data back to you in a manner that you can work through and obtain to see where you're having improvements or where improvements may still need to be made. The goal here, again, is to assess the changes in these metrics before and after that continuous monitoring implementation. So looking to see where your outcomes improvements have come or are being associated with from your continuous capnography or your continuous arterial saturation pulse ox monitoring. There are three main components to the program that I want to outline here. The first is the benchmarking, looking at the hospital's own benchmark against national averages. The second being the actual implementation phase, the post-op implementation on the medical surgical floors. And lastly is those actual data, those actual metrics, looking at the measurements and how data has changed before and after implementation. Next. We'll be looking at this data really going from the diagnostic, so your post-op respiratory insufficiency, arrest, failure, your PSI-11, to the actual interventional, such as your rapid response calls, your unplanned intubations, your reversal or naloxone agent use, to the true outcome measurements, such as hospital length of stay, mortality, and hospital charges. As you can see from the chart here, most all of the data we're pulling is existing ICD-9 and ICD-10 billing code data. So it's already available information that's already being submitted out to CMS that we're just having a pure data pull to obtain and work through. The other metrics are generally already available items either from your EMR or other groups within, such as pharmacy, such as like your naloxone usage. Now the list here is a comprehensive of all the metrics we're trying to look at that are all respiratory related. If your hospital or group didn't have all these metrics, we can look at a subset, but the main goal is the more metrics we're able to look at, the more we're able to understand the full picture and a more complete look at how respiratory metrics has changed after continuous monitoring. Next, please. So to go a little deeper into each of the three components, the first component here is on the benchmarking. The benchmarking against your hospital after risk adjusting to compare against both regional or national averages. And so we're pulling from nationwide inpatient sample, the NIS database, to help compare how hospitals' current metrics compare against nationally. So you can see one example here in the chart where we're looking at the hospitals rate, and this is a makeshift hospitals data, compared to national averages, and then after risk adjusting. So looking at the respiratory insufficiency, arrest and failure, post-op respiratory failure, post-op respiratory failure from specific procedures, code blues, and really looking at where the absolute rate compared to the risk-adjusted rate is. Again, this is just one subset, one example of some of the benchmarking data, but can slice it in a number of ways to look at it both, again, regionally compared to other hospitals within the area, like size hospitals, or national averages as a whole. Next, please. Second component here is the actual implementation of that continuous capnography, continuous SpO2 monitoring. And so the program will look at ideally 1 to 2 years of pre-implementation data. So before continuous monitoring was used on the medical surgical floors, what were the metrics that were seen from a respiratory standpoint, and then a minimum of 6 to 12 months post-monitoring, how those metrics have changed. And so we can pull every 6 months following or every year following and have continuous updates of that data, but namely looking to really see that before and after associative implementation changes in the data. Now, some of the best results here is when we're able to pull out which patients have had continuous monitoring and really looking at that protocol-driven continuous monitoring to show the patients before and after and how those associative changes have taken place. Next, please. The third component here is the actual metrics, the actual report out. And so this is the physical data. Again, we're having one example here looking at some of your true economic and outcomes related measurements. So in the example here, the report outlines the before and the after from the blue to the yellow, and again, those same respiratory related metrics. And then what does that actually mean for you for the hospital themselves? So what is the average per outcome pre-capnography length of stay? And then what is the post length of stay? What are the associated charges and what are changes in mortality? Again, this is one example here looking at a makeshift hospital on how the data has gone from before to after. The data we would present as part of the report, and we have presented, is much more comprehensive. It's much longer than just this and goes into a lot more details for each of those different respiratory-related metrics that we showed at the beginning. So you can look at specifically areas where improvements may have made or where places where there's still improvements to be made, identifying both where things have gone for the better or where you still need to put additional work or metrics into. Next, please. What this data actually means for you here is really looking at and having visibility to improved outcomes in your hospital. Obviously, data is continuously being collected, but not always used to actually drive improved outcomes. We want to be able to help partner with facilities to provide your own data back to be able to identify changes needed and help improve the hospital's patient outcomes. We can track that, it can help you track your investment after you put the time, the resources, and the physical product investments into continuous monitoring, really better understanding how that has worked, how it has improved outcomes, how it has improved workflow, how it has had associated changes, validating that earlier indicator that continuous monitoring can provide. From here, there are opportunities to publish the data, to create case studies, to show examples. We'll talk about here in a minute with Barton, who is able to provide plenty of examples of how they've been able to take this data and further their own hospital understanding of their quality metrics. And lastly, working with the forces of magnetism. The data here has been used to show the outcomes improvements and the demonstrated work being done to improve outcomes as part of the forces of magnetism qualifications that are needed as well. So there are plenty of means and plenty of ways to be able to further interpret your own data for needs that you may have or requirements that you may have by being able to have us help partner to pull that data and show you the changes that have occurred. Next, please. And so with that, I want to introduce the group from Barton Healthcare that is able to join us today. It's my pleasure to introduce Christine O'Farrell, the Director of Quality Management, Mary Kay Sennings, Pulmonary Services Manager, and Dawn Evans, Patient Safety Officer. We're going to have Barton help talk through some of their experiences with this program, the data, and what the data has meant for them and how they have used that data. So with that, I'm going to go ahead and ask a few questions. The first I'll ask to the Barton Healthcare group is if you could help explain and provide an overview of your experience in participating in this program.
Good morning. This is Christine O'Farrell. When we had the program in place for about 2 years, we realized that we wanted to go back and look at the impact of the program, and we had limited internal data such as in-house code blues, rapid response, our mortality rates, and we realized we had to partner with Medtronic to dig a little deeper and get more significant data out of the system and the billing data that was available. And so it was very beneficial for us and had a great experience. We were able to get our respiratory compromise rates, which showed that we had a slightly higher than national average rate of respiratory compromise in the patients that we see here. And then also it was able to show that our post-op respiratory events were actually significantly lower than the national average. So that was great. And our mortality rate, our length of stay reports, and the financial impact was very beneficial for us as well.
Excellent. So to kind of continue with that aspect, what motivated Barton to want to obtain or to pull this data? What was the initial trigger that said you guys wanted to understand your metrics better?
Well, a couple things happened. We had our Joint Commission accreditation survey, and we used our capnography performance improvement project to really showcase a successful program. And after that survey, we wanted to dig a little deeper because as any organization, we did not want to increase the number of alarms, and that was something that we had struggled with. And the staff, we did have some pushback from medical staff and staff members on our alarms. So we wanted to go back and see what impact it had and then provide that feedback to everyone so that we could show that it was successful and we could gain support on very important things such as lowering our in-house code blues and our in-house mortalities.
Excellent. That's great. And to kind of go a little further, what specific metrics of the reporting do you feel were most meaningful or had the biggest takeaway for your group?
Well, I know, the doctors initially were very outspoken about the alarms, and once they saw the in-house code blues, the mortality, the mortalities showing a decrease from 2012, which was before we implemented it, to 2016, then the buy-in was significant. Everyone, even one life is significant here in a small hospital, and it meant a lot to us to be able to show that we were actually saving lives with this performance improvement program.
Excellent. And can you speak a little bit about how it was to pull the data, the process, or how easy it was to obtain the actual data? Well,
for the purposes of this webinar, the data was, I think it would have been impossible for us to pull it. We don't really have a large staff, or we don't have data analysts here at Barton. So without partnering with Medtronic, we would not have been able to obtain all of the data that we did.
That's great. Obviously, one of our goals is to truly partner and make that easier obtainable information. It's sharing your own data back with you so you can interpret and further understand those results. And another question I'll ask here is around what has Barton done with the data they obtained from this program, or what has Barton looked to do differently since you saw the results from this program?
We were able to submit it to the Joint Commission as a best practice submission, and they did recently publish that in one of their, The Source, the Joint Commission, The Source, just recently published it. And we also submitted it to the Society of Technology and Anesthesia Conference, and we were awarded the best clinical application for that. And Don Evans, our patient safety officer, submitted it to the National Patient Safety Congress, and that abstract has been picked up as a poster presentation.
Excellent. Yeah, there's been some great examples of where you've been able to provide that data to the Source publication, which was an excellent and highly recommended everyone take a look at, as well as the STA abstract was a great presentation of that data that won an award for the clinical evidence and clinical data for the conference there. So congratulations on the great work you guys have turned out from the evidence and from the data.
Thank you.
Last question I want to ask is, before we turn it over to the larger Q&A, is around the value in participating in the program and any advice or I guess experiences you'd want to share with those on the call on further than what you've already shared here today.
So hi everyone, this is Dawn Evans, the Patient Safety Officer. I know it has been a journey for us, as it is with any improvement program that you put into place. You know, you go in with the best intents, you review the evidence, you implement based on that, and then you come back and reevaluate. And so we have been on this journey for a few years now, and during that time, you know, we've really learned that we need to collaborate, and we've had a multidisciplinary work group come together that includes our physicians and our director of anesthesiology to help us with this program. Through that, we have made adjustments, you know, and as you get data, you go back and you plan it and you study it, and then you make revisions and then you move forward. So we've had a lot of, I guess, pearls that we have learned through this journey. Including staff is key, and continually reinforcing the use of the capnography was something that we learned we needed to do. It's a change, and change takes time, and it has implementation dips. And we've gotten to the point where we are consistently now applying these on the correct patients. And that's another thing, is just figuring out which patient population really needs the monitoring and which patient populations don't require the monitoring. And then, of course, we were challenged with the clinical alarm fatigue, and partnering with Medtronic and being able to pull the data, we were able to make adjustments in our alarm parameters, which have significantly decreased our alarm level rate. And so, as Christine mentioned, you know, with Joint Commission and the National Patient Safety Goals, that's something that we pay particular attention to. So we continue to address this program and, you know, study our results, look at our data, and refine as we continue on this journey.
No, that's perfect. Like you said, it truly is a journey, and it doesn't just happen overnight. So the experiences you've had and the process you've gone through is a wonderful best practice to continue to share and help with other support of other hospitals. So I know we have a number, Heather, I believe we'll pass it back to yourself here for a number of questions and answers that have come in from the audience that we want to ensure we have plenty of time to address.
Yes, thank you, Keith, Dave, and Christine, Mary Kay, and Don for that fantastic Q&A. As Keith mentioned, we will now begin today's question and answer session with the audience. Audience members, if you have any questions, you can submit them by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try and get through as many questions as we have time for today. The first question is for the Barton Health team. It is, who championed this approach at your hospital?
Our patient safety officer, Dawn, is the one who championed it, working closely with our risk manager.
Perfect, thank you. The next question is also for the Barton Health leaders. What criteria do you use to determine which patients receive capnography monitoring?
Hi, this is Mary Kay Sennings from Pulmonary Services Manager. We developed a list of guidelines which was pretty extensive, and we keep tweaking it. We monitor patients, any patients with a BMI greater than 35 on opiates, if they're suspected or diagnosed OSA, pediatric patients and adolescent patients that are on opiates, any patient 65 or older who's opiate naive, we monitor. If they have an intraspinal opiate, we monitor for at least 24 hours after the last bolus. If they're on opiates and benzos by any route, if they have a stop bang, we screen all of our patients with the stop bang screening for OSA. If they have a stop bang score of 5 or greater, then we monitor. And any patient that's based on nurse criteria or nurse assessment, then and feels the need, then the nurse can make the decision to also monitor the patient.
That makes sense. Thank you. The next question would be, can you talk a little bit more about how you are capturing your code blue and RRT data? I've been unable to find the code to pull it out of the EMR. So what are you using?
So this is Dawn Evans again, the Patient Safety Officer at Barton Health. We are a small organization, and we require all of our code blues within the organization be entered into our electronic event reporting system, as well as all of our rapid response team activations. That way we're able to track it. And then we're also able to look at those through our code blue committee and our patient safety committees, where we can track and trend data, identify trends and issues that we may need to dive a little bit deeper into.
That makes sense. Thank you, Don. The next question would be for you guys at Barton. What institutions would you recommend you doing the same program, and why? I guess we can open that up to Dave and Keith as well.
Yeah, so this is Keith. I think largely the Golda program is to help facilitate and help assist facilities that have begun continuous monitoring, whether it be continuous SpO2 or capnography on the medical surgical floors, to better understand how that investment in time and resources and workflow has actually impacted the patient safety itself. So we can look at this program from a pre-implementation and benchmarking against national averages to the institutions that have begun monitoring and really looking to pull out the data around how that has helped associate improvement in outcomes. So I guess the main part of that would be whether you're looking for just the benchmarking all the way to the full post-implementation results. The best institutions are those that have looked to address the continuous monitoring issue and basically want to get that own data information back.
That makes sense. Thank you, Keith. This next question will bounce back to the Barton Health team. How did you sustain the improvements?
With case settings again, we continually provide education to our staff and encourage the staff to educate the patients. Medtronic has partnered with us to provide education for the staff.
Also, our committee, our multidisciplinary committee, has been meeting monthly for about 3 years. As any performance improvement program, if you've ever participated in one, it continues to grow. It's like peeling the layers of an onion, and more action items spin off, and we look at the data and we make improvements, and so it's a continuous improvement process. And so I think keeping that focus on it with our monthly meetings has really helped us. And then reporting that data up through the committees to our board of directors, which the board of directors did give us a substantial amount of money, close to $200,000 initially, to purchase this additional equipment that was not budgeted. So making sure that they get the feedback that it has really impacted the quality and safety of our care has been very significant.
That's a great point, thank you. And that rolls into our next question from an audience member, which is, what was the role of executive leadership in this project?
So Dawn heads up our patient safety committee, and we did have a respiratory event in 2012, and it brought to light that we needed to dig a little deeper as far as our evidence-based best practices around respiratory compromise. And so we were able to use that to go to our board of directors to request some additional funds to implement expanded capabilities in our organization. So we expanded it outside of the operating room into areas like the emergency department, medical imaging, places where we're doing procedural sedation, and have closer monitoring of those patients. So sorry, I forgot the question. Did I answer it?
I think so. The role of the executive leadership in this project?
Yeah, so bringing it up the chain of command from patient safety to the board of directors, it was crucial for us because we had no way to fund it without their buy-in.
Great point. The next question for the Barton Health team, similar to another one, but is how do you continue to monitor performance?
So we can get the monthly data that we have internally that goes to patient safety committee, the mortality, in-house code blues, the rapid responses, the number of Narcan uses, and then Mary Kay and her team monitor the appropriate application of the technology, the compliance rates on that.
That makes sense. Thank you. The next question would be, sorry, they're coming in. What new initiatives have you started since reviewing this report data?
Continue to work to reduce the alarms. That's probably the biggest thing that we're working on now. Mary Kay, do you want to talk about our alarm reduction?
Medtronic partnered with us to look at our alarms and look at our default alarm settings. So we monitored for about 3 months all of our alarms, and they pulled the data for us for that. They made some suggestions for our default alarms, and we made some of those changes and then monitored it again. And we lowered our low CO2 alarms by 39% and our low respiratory alarm rate by 52%. So that made a significant impact with our alarm fatigue.
Great, thank you. The next question, we might have touched on it a little earlier, but for the Barton Health team, what has been the response of your hospital administration in the results of this program? In their mind, does this data justify the investment made in time, money, and other resources towards implementation?
Well, it's kind of funny because our medical staff was probably the most outspoken about the alarms. And we brought the data to our medical executive committee, and when they saw how much we had improved our safety and quality, they were all patting each other on the back and very proud of our performance. And so I think it's crucial to share that data because it's human nature to kind of want to push back about more technology or more alarms, and knowing that we're continuing to work on improving and that we are significantly impacting our community's quality and safety. It made all the difference as far as buy-in.
Mm-hmm.
Great. Thank you for clarifying that. The next question for you guys at Barton would be, what has Barton done with the data obtained from this program, or what have you looked to do differently in your clinical practice since seeing the results of the program?
Yeah, we continue to look at the data so that we can improve our education and our implementation, and also to reduce the alarms and to share it with our staff, medical staff, and board of directors so that we keep it on the forefront. And as I said, we used it with the Joint Commission to really showcase our performance improvement program.
We're also looking at our guidelines and revising those a little bit to make sure that we're monitoring the appropriate patients.
Perfect. That makes sense. Thank you, guys. This next question would be, how did you calculate the cost savings for these patients monitored, e.g. compare to national database or contrast to like patients who did not receive monitoring, or compare to historical data?
This is Keith. I'll jump in and go with this one. With part of the program, there are a couple different aspects or ways we can look at it. Because there's not a specific billing code directly to those patients that have capnography or continuous monitoring, one aspect is if the hospital has a protocol around which patients get monitored, we can separate those that have and those that have not gotten continuous monitoring. If there is not a very focused protocol around that, it's an associative before and after. So you're looking at a blend of the patients in the post-implementation phase that some had and some did not have continuous monitoring, and where it's an associative improvement based on the continuous monitoring that has been implemented, as well as other programs or policies that may have driven improvements in the respiratory metrics. So from a cost perspective, we're using published available information around national averages for length of stay, for costs of specific respiratory metrics. A lot of the information is out there as far as when you do a very deep dive into the publication, the literature, and searching, all that's out there from a national average and cost perspective. So some of the information we can get from national databases. Other information is pulled from the publications. And so we are happy to kind of talk about that further for anyone that is interested in discussing that mythology there, for sure.
Great. Thank you for clarifying that, Keith. This next question is for the Barton Health team. I know we've talked a lot about it, alarm fatigue. So what steps are you taking to reduce alarms?
Well, alarm fatigue was a big obstacle with this program. And so we did a lot of education with the staff and a lot of education with the patients to make sure that they kept their cannulas in place, that the patients knew what this was being used for and why they were being monitored, why it was so important. And then Medtronic came in and did an alarm audit that I talked about a little earlier. And we did look at our default alarm settings, and we found that we did have them set pretty tightly. So we widened those parameters a little bit, and that made a huge difference. And so hopefully we're reducing our alarm fatigue.
Yeah, and this is Dawn. We just want to make sure that we mention that with the alarm parameter adjustments that we have not, I'm going to knock on wood, have not seen any adverse patient events as a result of these alarm parameter adjustments.
Exactly. I think the nurses are responding more quickly because there's not so many alarms. They're not ignoring alarms any longer. When they get an alarm, that it's probably a significant alarm.
Right. Another point we might want to make is prior to implementation of this, I know Dawn had headed up a work group to address the Joint Commission Sentinel event warning on alarm management, and so that committee successfully reduced our overall alarms by 40% before we even added the capnography.
Got it. Thank you guys so much for clarifying that. We do have a follow-up question about alarms, which is, what were your alarms initially set at, and where are they now?
And just so that you all realize, we are in Lake Tahoe at altitude of almost 6,300 feet. So our normal CO2 ranges are a little bit different. But we had our high and low CO2 values set at 60 and 15, and we reduced the low end tidal CO2 value to 10. Our respiratory rate alarms, the low was set at 8, and we reduced it to 6. They also have a value called sat seconds, which had been set at 50, and we increased that to 100. Those were the only changes we made, and we've made a significant impact by doing that.
Great, thank you for clarifying that. All right, the next question is, how did partnering with Medtronic make obtaining your data easier, and how much work or time was involved?
Well, we were able to pull some internal data. It took many hours of work to go back through 2012 and get our internal data, but we would not have been able to dig as deep as we did without partnering with Medtronic. As I said, they were able to pull our length of stay data and then benchmark that nationally and give us a dollar amount, our return on investment, lives saved. I don't even know how you can put a dollar amount on that, but I think having the increased awareness and then building the performance improvement program on a technology like capnography, which alarms and brings the attention of the nurse to the bedside, was crucial, because you can do a lot of things, but when you get busy in a hospital without that technology to trigger a response from a human being, things can go unnoticed, and that's when you see more code blues happening. And so it's crucial to us to partner with Medtronic.
Awesome. Thanks for informing us on that one. Another question here is, if the results you had seen had not been as positive as they were, what do you feel you could have done differently to address? Maybe that can also go to Keith or Dave.
I would really look to Barton here and get a little bit of their perspective. Obviously, they showed some very positive results from their implementation of continuous monitoring, and I guess I'd ask the question to the Barton group around, what else can you learn from the results, or where there may be improvements that could be made, or where, there's still areas that could be addressed in other means.
Okay, so one thing we did identify is kind of the next steps is looking at identifying these patients earlier on the outpatient side. So in the pre-op offices, we're educating people to look at stop bang scores and try and address potential sleep apnea prior to having surgery, and also chronic narcotic patients. We need to address that and see how that will impact them post-operatively. And so that's our next journey, is expanding it to the outpatient clinics, being more proactive, so we're not identifying it on the day of admission. We also, with the stop bang, we're using a letter that we send to all of the primary care and surgery offices when a patient's identified at risk here in the hospital, to follow up to make sure that they, if it's needed, that they get a sleep study performed so that they can address the issue once they go back to their primary care physician.
Great, thank you so much. I do have a clarifying question for Keith, which is, what is stat seconds. Which was a follow-up to the alarm setting. Yes,
the stat seconds is an algorithm that is based into the Nellcore continuous pulse oximetry that's looking at the desaturations and essentially the time and the drops in the solution. It's a severity frequency essentially. So understanding the desaturations and how long, the repetitive impact of them versus essentially the severity of the frequency of those desaturations. So it's an additional built-in algorithm that helps to understand when it's a short desaturation compared to repetitive and severity of desaturation.
Great. Thank you so much for clarifying that, Keith. That was our last question for the day. So I do want to thank Dave, Keith, Christine, Mary Kay, and Don for that excellent presentation and for all of our audience members for participating in the Q&A today. Enjoy the rest of your day, and we look forward to having you join us on future webinars.